And so welcome to Nephrology Province-Wide Round, and it's a great pleasure to introduce Dr. Gaylene Hargrove, who's a clinical assistant professor at UBC based in Victoria at Vancouver Island Health Authority, who actually is the provincial medical director for the our palliative care provincial group, and Sarah Thomas, who works with her as well, a number of other provincial projects, and they're going to give us an idea of what we're doing here in BC in terms of integration of palliative care. So I'm going to turn it over to them, and thank you for coming.
Thank you so much, Adira, for the kind introduction, and I want to add some further words regarding my esteemed colleague, Sarah. So she is the mitochondria of our cell. She is the powerhouse. She's been our project manager for the Integrated Palliative Nephrology Project since its inception. And so I owe a debt of gratitude to her and all the members of our Palliative Care Committee, our patient partners, and there will be further acknowledgements towards the end as well. I'm going to start by inviting you to take a moment to self-reflect. Think about the patient death in the most recent past of a patient that you had come to know well. You developed a relationship. Ask yourself the following questions. Did the patient have an opportunity to express his or her wishes around end of life well in advance of the end? Were those wishes documented? Was the delivery of care at the end of life concordant with those expressed wishes? Where was the place of death? Was that in alignment with what the patient had wanted? And was the patient informed of the options around death and dying? And were you aware of the options? Were you aware of the resources available? If so, were those resources able to be accessed in a timely and seamless manner? If those questions cause you to be gripped with moral distress, that's okay, you're not alone. Because if the answers to any of those questions is no, then I'm hopeful that the information Sarah and I will present today will be helpful. And usually, so I'll just begin by stating the objectives. Many thanks to Pam and Roz for coordinating this, and to Roz for distributing the invite with these objectives. Often we start with a clinical case or a patient story. This will come later because my personal experience will dictate that it is very challenging to deliver an effective presentation when you are blubbering. So that will come later. So why the need for the IPN? Well, through an environmental scan, we have discovered that barriers exist to accessing palliative care at the end of life for our CKD patients, especially those receiving dialysis treatment. And these are difficult conversations that are often deferred until the end. And we'll endeavor to describe the BC Renal Integrated Palliative Nephrology Project and why the need. We'll discuss what tools and resources have been developed and how they are intended to be used, including the following. And we actually have some hard copies of these documents available today, and all of them are available on the BC Renal website and can be ordered as well. Discuss how to sustain positive changes in practice to improve quality of care for our patients who benefit from a palliative approach. So I will hand it over to Sarah now.
Thanks, Dr. Hargrove. It's a pleasure to speak to you all today to talk about the great work we've done with our BC Renal Palliative Care Committee. As Dr. Hargrove said, we have shortened it to IPN because, as you can imagine, when we're emailing every day, Integrated Palliative Nephrology, so it is an IPN. If you're wondering why we're using that term, IPN is kind of our, it's affectionately known as that. So the purpose of our project was to develop and implement a provincial strategy to effectively integrate a palliative approach for all CKD patients under the care of nephrologists in BC. That purpose statement alone overwhelmed me, right? Knowing that we have so many patients in BC that we wanted to integrate a palliative approach. In order to actually do this, we had to chunk it down into bite-sized pieces. And even though I say bite-sized, it really wasn't bite-sized, but we wanted to focus on 5 key areas for the IPN project. One being enhancing renal clinician engagement in ACP discussions. Education, mostly around the serious illness conversation, but other education opportunities such as advanced care planning, MESAS, tools and resources. We knew this was going to bring some culture change to the front line and in the workflow, so we wanted to form partnerships with our other colleagues at BC Centre for Palliative Care, our First Nations Health Authority, our family physicians, our hospices regionally, and even with the Ministry of Health, we have formed partnerships and we've been able to speak with the Ministry of Health Palliative Care Committee. We focused on document development, and that doesn't just mean for patients. It was actually for staff as well, knowing that there is a lot of anxiety around palliative care and end-of-life discussions, so we wanted to make sure we had documents to support our staff as well, and our patients. And of course, we wanted to evaluate what this work is all about. So as a project manager, this is a very busy slide, and I'm not going to talk about every detail, but we had to sort of look at a work plan. And what this is there's the 4 deliverables on top: education, dissemination and culture change, document development, and evaluation. And underneath are the work packages in green. Now, I'm not going to go into all the details of the work packages, but there was a lot of work involved in doing this provincial strategy. We knew we needed a lot of manpower, we needed a lot of people, a lot of input from the province. So I'm happy to say that this is actually green now, and at the beginning it was all red. We hadn't started all of these components, and in the last 2.5 to 3 years we've been able to complete all this. So we're really proud of the work we've done, and we've been able to really engage a lot of people from around BC. So I can, if you want to know more about that, I'm certainly happy to share later on. So what is a palliative approach? You've probably heard the word, you've probably heard the buzz. If you're an old-timer like me, palliative meant end of life. It meant the last days or weeks of life. But a palliative approach is actually not that at all, right? Really, what it focuses on are the concerns, hopes, and fears of patients and family. Considers physical, emotional, and spiritual concerns. Ensures care is respectful and supportive of patients in dignity and autonomy. And the treatment plan is aligned with patient wishes. Really, it's the gold standard of what we should be doing, right? So that is a palliative approach. It's not about end of life. So why is a palliative approach needed for our patients? We know the impact of symptom burden is high in our patients. And we know from studies that done by Dr. Sarah Davison in Edmonton, it suggests that 60% of our patients actually regret starting dialysis. We know that suboptimal symptom management can lead to depression, affect relationships, cognition and mobility. We know this, which is very all-consuming to our patients. And often they feel intense guilt or shame for burdening their family. Many patients have to drive an hour there to dialysis and back. It's a big burden. The physical issues that they have, it's a huge burden for some of our patients. So we looked at, reasons why patients might choose to stop dialysis. And we know that they might have worsened quality of life, intolerable suffering. They have had too many losses, the loss of independence, their limbs, mobility, maybe financial burdens, well-being. I never really wanted to start dialysis in the first place. This could be a reason. And, of course, sudden change in physical and functional status. We also looked at why patients continue on dialysis despite their, poor quality of life. What other choice do I have? Death, right? I can't leave my spouse, my child. Who's going to take care of them? my pet even. It would be suicide, my religious, and this came up a lot throughout the project. Many of our patient partners felt that it was suicide. And we do address that in some of our documents. I was still hoping for a transplant. Dialysis is the bridge to transplant, right? So there's a lot of things that patients are feeling. So the purpose of our documents and our creation of this, and the whole project, to be honest, is to help patients and clinicians explore these difficult conversations. There's a lot of anxiety from both ends. So we wanted to make shared decision-making tools that are designed to help healthcare professionals and patients work together to make a decision that's best for the patient. And the optimal decision for the patient takes into account evidence-based information about the available options that are available for our patients, the provider's knowledge and experience, and patient values and preferences. Okay, so that's the purpose. You know, stopping dialysis, some of the crucial steps before deciding. We want to encourage patients to share their thoughts with their loved ones. And we have created a document that helps them have these conversations. Patients should discuss with their family physician or nurse practitioner. Talk to your nephrologist or other team members. Patients should ask a lot of questions. Suggest patients talk to their community team or spiritual care. Ensure patient feels satisfied that all questions have been answered. So we have a document about that for our patients to have these difficult conversations, knowing it's not going to be easy. We've also developed another document called Frequently Asked Questions. We know this can be a taboo subject. Perhaps patients don't know. Maybe they're afraid to open that door and ask the questions. So we have developed a document that has all of the questions they may ask. If I stop dialysis, what happens next? Will I see you again? Meaning my nephrology team, my nephrologist, my nurse. Will I see you again? Are you just going to send me off? How long can I live after stopping dialysis? We know this is a big concern, right? Will I, have any symptoms? Will I experience pain is a big concern. Our patient partners address this as well. Will I get puffy? Can I drink? Will I maintain mental alertness? These are all questions our patients had. Can I change my mind and start dialysis again? We wanted to make sure all of the questions were answered in our documents. What are palliative care services? How am I referred once I stop dialysis? How can hospice support me? Do I have to stop dialysis to get into hospice? This was a big question and something we're addressing with the Ministry of Health right now. We're really working with them to change that focus, right? Because we know dialysis can be palliative, it can be symptom management. So this is something we're also working behind the scenes on. Will I have the choice about where I die? Can I choose to die at home? How do I plan for home death? And we also realized from our work that not everybody wants a home death. Many patients don't. So we've addressed that in the book as well, in our documents. Can I choose to die in hospital where I feel comfortable? That's another thing. They know their team, their renal team is there. So these are some questions that we've addressed and we've answered, and our patients have helped with this. So I think I will pass it back to Dr. Hargrove, who's going to talk a little bit more about the patient story and the rest.
Thank you, Sarah. So one of the most gratifying aspects of working collaboratively with patient partners is we get to hear the representatives describe how they feel things could be better. They drive us to do better. And so one of the things one of our patient partners in particular was very vocal about was coming up with a checklist. So we as healthcare professionals, we've come to learn the value and benefit of a checklist, right? We have the surgical checklist. It has revolutionized the quality of care delivered perioperatively. No one would argue with that. So why not come up with a checklist in this context? It may seem a bit strange, but this was what one of our patient partners was pretty clear about that we should endeavor to deliver. So what are the benefits? It provides a standardized approach. Keeping in mind one size doesn't fit all. We can, customize it in some instances, but it's a reminder. It keeps users and participants on task. It ensures that nothing is missed or forgotten. It helps to reduce fear and anxiety. Hopefully you're answering some questions along the way. And it provides an organizational template or model. So specific considerations that we came up with and are described in some of our documents quite clearly, that a substitute decision maker should be identified as early on as possible. This should be documented in the advanced care plan, and the loved one must know where the documents are. Ensure the SDM knows your wishes, values, and preferences. Is your will and power of attorney documented and up to date? And if you have concerns regarding symptom management, bring them to the attention of your care team, whoever that may be. It may be nephrologist, primary care physician if involved, home and community care team, palliative care physician, anyone who's been involved. Ensure that you're registered with home and community care or community health services. In the Greater Victoria area, that is the gateway to hospice registration. Register for BC Palliative Care benefits. So this is for the physician to complete. It doesn't always have to be the nephrologist. It can be any physician. But in order for patients to gain access to financial aid for services, medications, et cetera, that they may benefit from at end of life, this can be very helpful. Discuss what your code status wishes to be. So this is the patient to discuss with the physician, and ensure the documents are completed and posted at home in a visible location. This is very important. Even if documented but secured away in a drawer, there is a possibility that a patient could be resuscitated against his or her will if found down in the home and someone doesn't know about that. Decide where you want to die and speak to your home dialysis team regarding removal of equipment and supplies. Is there other medical equipment to move? For example, wheelchair, walker, scooter, hospital bed, oxygen tank. You can even provide some advice about what to do with those things. There are donation depots that you can use to drop them off. Make funeral arrangements and ensure that loved ones know who to call and what to do. Ensure your healthcare team is aware of your cultural and religious beliefs and rituals. And this may not be for all to consider, but maybe plant the seed that if there are those that you're estranged from, that you'd like to reconnect with and make the peace, do so. Ensure that any dependent loved ones are going to be cared for following your death. And for the patient story that I'm going to share, she had to be very concerned about her dog. And, we sometimes forget about these things. Very important to reassure the patient that he or she is not alone, support's available, and the renal care team is available to provide assistance. So I'd like to share my patient's story, and she was a special woman who contributed a great deal of time as a patient partner to our IPN project team. She was very instrumental in coming up with the checklist and for contributing ideas to the stopping dialysis documents. And our first meeting was in January 2018. So in terms of her health history, she had long-standing hypertension, osteoarthritis, a previous tibial osteotomy, which proved to be extremely painful, and chronic kidney disease. She was referred to a nephrologist in 2005 when her GFR was 32 29 to 32, and she was 62 years of age at the time. And this proved to be very slowly progressive. She engaged in optimal self-management every step of the way. She was referred to the kidney care clinic when her GFR was 22. That was in 2015. And in fact, it was very helpful for me to read the social work consult at the time. And I'll just describe this quote. She always likes to know about her health matters as it gives her a sense of control, and she feels sure of what she needs to do to manage her condition. She can then make the necessary plan and execute this. When she realized she might need dialysis, she researched the options thoroughly and chose peritoneal dialysis. And it's noteworthy to point out that her most significant symptom impacting her quality of life was not any symptom related to her CKD, but in fact it was joint pain. And it was very severe, unrelenting, resulted in poor sleep and reduced mobility. And in terms of her personal history, she had a university education, Bachelor of Science, and she worked as a research assistant for a number of years, later completed her social work degree. She was hired at the William Head Correctional Institution, and in fact she became the director of social work. Now, she had a son with her first husband, and he died of a brain tumor at 8 weeks old. And their marriage ended not long after that. Interestingly, she met her second partner while skydiving. They never married, but they were together for 42 years. And she was there at his bedside when he died at home of metastatic colon cancer in 2012. And Jan, she directly assisted with his palliative care. So in 2017, recall that she was first referred to a nephrologist in 2005. She had her peritoneal dialysis catheter insertion performed, and she completed her training in the fall, and she had no issues with dialysis at all. She did very well with it. However, she was experiencing increasing pain, reduced mobility, and over time she was requiring aids for walking. She did not require any hospitalization until December 2018, so a little over a year after she started PD. And while helping a friend lift a wheelchair into the trunk of the car, she developed a fragility fracture of her hip. And in fact, she had initially presented to the emergency department, and because there was no, quote, trauma, they actually discharged her with the advice to take some Tylenol 3. Didn't image, and she walked on that hip for the next 3 weeks and finally represented, this time to a different hospital emergency department. Imaging showed a very terribly displaced fragility fracture. So she actually underwent on December 10th a hemiarthroplasty. And she did well in the perioperative period, but 8 days later, she was saying to the nurse who was going to do her PD exchange in the morning, I can't do this anymore. My quality of life is no longer acceptable. What's the point of continuing? I don't want to carry on for weeks or months. I want MAID, and I've done my research. And this poor nurse was completely caught off guard. This was a bit of a blindside. And so kudos to this nurse who, instead of working to convince her that, you know, that she was just going through a rough time, you know, we're here to help you, just take some more time. This seems impulsive or rash, because that's often our initial reaction. He left, he came to me, he came to me, and he told me what she had expressed. And I could tell he was in a state of moral distress. And so I reassured him, I thanked him for coming to me immediately with this, and I went to her. And she was not delirious, she was not thinking impulsively. In fact, she informed me she'd been thinking about this day for the last 6 to 12 months. And so I'm extremely grateful that in Island Health we have a very robust and well-organized MAID referral system. So she underwent her first MAID assessment the same day that she expressed her wish to me, and she was determined to be eligible. And then she had her second assessment on the 20th, 2 days later, confirmed yes, she's eligible, and in fact she fulfilled the criteria for expedited provision, because Jan knew very well that if she took all of the opioids that were being offered and stopped dialysis, that she would soon become incapable, and one must be capable on the day of provision. So a date was decided on. Her sister came from Illinois, and on the 27th, all of the following were present at Jan's request. So her primary care physician, who she'd known for over 20 years, 2 home dialysis clinic nurses, nephrologists who she'd known for 12 to 13 years, and the MAID provider. We were all there at the bedside. And her sister afterwards described this as an elegant departure. So this is what Jan said in the last 30 minutes of her life. Being a member of the IPN Project Working Group was one of the most gratifying things I've ever done. If I can help even one other patient with CKD feel empowered and informed regarding planning for end of life, then going through this was all worth it. The checklist is so important. That has helped reduce my fear and anxiety, keeping me on track, completing everything on the checklist reassures me things will go smoothly. And she handed a note to me. Regarding the stopping dialysis documents, we need to add a paragraph and link regarding information about MAID. It logically ties to the decision to stop dialysis, especially for those like me who still have residual kidney function. I'll hand it back over to Sarah.
Okay. So I'm sure you've seen, if you are in a dialysis unit, you may have seen our documents circulating. Maybe not, but that's okay. I'm introducing them to you today. You can see at the bottom that we actually dedicated the books to Jan for her, she was just so instrumental in the whole development and the direction of our documents, and we couldn't have developed them without her input. She was just remarkable and very open and with sharing. So it's lovely that we can dedicate that to her, and I think we've also reached out to her sister in Illinois to let her know that we have dedicated these documents. So the first document with the tree is more of a conversation document, conversations to have with your loved ones, to have with your family physician, your nephrologist. It opens the door for some of our patients. And the other document, the frequently asked questions, is the checklist as well as the questions that we've addressed in this presentation. You'll notice that we've kind of gone with a fall leaf motif. It's hard to find a graphic that talks about end of life, but we thought this was very fitting, and the seasons of life, that's kind of why we chose that, just as a sidebar, if you're a visual person. We've worked very hard with the KCC, and thanks, Mike, for your help with that. We have a transitioning to conservative care for our patients who choose not to start dialysis, knowing that our patients, it might be a long journey. So it's a 6-step guide on having conversations, symptom management, even an emergency plan if a patient's symptoms become so bad that they need to who to call, what medication to take. There's a whole plan in this guide, and it really helps our patients feel less anxiety as they're approaching end of life. So this is also a great guide for our patients in the KCC clinic. During our environmental scan at the beginning of our project, we realized that clinicians have just as much anxiety as patients having conversations. How do you start a conversation? I don't want to open a can of worms. You know, I don't know how to start the conversation. And we recognize that we want to support our clinicians. So we've created this journey map to remind clinicians to have conversations at certain sentinel events or big sort of milestones in a patient's renal journey, starting from chronic kidney disease, pre-dialysis. As we start to think about your options and preparations, it's a good time to discuss your goals and preferences. Is that okay? And then you can see, you know, dialysis initiation, maybe it's time to re-explore that with the patient and to see if their goals are still aligned. After a hospitalization or a sentinel event, dialysis access issues. We know our patients, this is a lot of stress for our patients, right? Their PD catheter stops working, their fistula stops working. We need to explore their goals of care at that time. And then of course, when they decide or if they're considering dialysis withdrawal. So this is just to help our clinicians open the conversation maybe. This isn't the whole conversation. We know this is taken from the Serious Illness Conversation Guide. So these are actually evidence-based, patient-approved words to start the conversation. And we know it's not going to be a linear road such as what is depicted here, but just to have those conversations and re-explore. We also have a patient one as well, which I don't have a picture of, but it's for the patient to come to a clinician and talk and to sort of open the conversation that way. And we're thinking of trying to integrate that into the Welcome to Dialysis package so patients know, maybe I should start having these conversations. So we're trying to work behind the scenes to get that in the Welcome to Dialysis package, and maybe the patients can remind them. As I mentioned at the beginning, we've done a lot of work with the Serious Illness Conversation, and if you don't know what the Serious Illness Conversation is, this is a tool that came out of the Dana-Farber Institute in the States, which is the Cancer Institute, and it was developed by patients and palliative care team members on how to have a patient-centered conversation. It is language patients feel is, I don't want to say soft, but it's nicer way to have a conversation. It explores key concepts, it explores goals of care, and it really helps have that conversation. And we've done a lot of training, and we're proud to say we've trained over 750 clinicians, renal clinicians in BC, on how to have this conversation, and we know that it's being done in the health authorities. There's also work being done with the BC Centre for Palliative Care right now on changing it to other languages, and they're just trialing it right now because it doesn't quite translate well word for word. So anyway, we have lots of serious illness conversation pocket guides if you'd like. And of course, we want to report to the Ministry of Health that we're doing a great job. We want to say, hey, our patients are having these conversations, we're doing a great job, but the only way we can capture this is in promise. We need to be able to capture this provincially so that we can report back to them and say, this many patients. So we know there might be a gap with the data entry, and so we wanted to really help people notify maybe a data entry clerk or someone to enter this data into promise. So we have developed this sort of worksheet to help with the transition and change in workflow, and maybe we might not need it in the future, but it's kind of a document to help bring that change. And then of course we have a wallet card to go with that, and that's for our patients so they can, on the back, I didn't show a copy of that, but it will say where their goals of care is located, who their decision makers are, should they not be able to speak. So there is a wallet card that they can keep. Okay? So I think I'll pass it back to Dr. Hargrove to sum it all up.
Thanks again, Sarah. So what we've learned, there are now educational and clinical resources that have been developed for planning for end of life with input from patients living and dying with chronic kidney disease. Now, in order to effectively use them, we should continue to establish relationships with patients and their loved ones, listening to their stories and learning what matters most, because these are crucial preparatory steps. We also learned that we need to optimize our collaboration with various instrumental disciplines such as home and community care nursing, palliative care and hospice staff, primary care physicians, our nephrologists, social work, renal nursing, and this is key to smooth transitioning for patients at end of life. Implementing a palliative approach further upstream will facilitate planning for end of life. And importantly, we wish to acknowledge all the members of our IPN working group, our patient partners, BC Renal. Without the sponsorship and support of Dr. Levin, we wouldn't be able to do this. And Sue Saunders has been a very effective leader in our group as well. She is the strategy lead of the Palliative Care Committee, and she provides really essential guidance along the way. The BC Centre for Palliative Care, they've been very effective collaborative partners in our work, Dr. Gillian Files and Carolyn Taylor. So they've been very helpful in getting the word out to palliative care teams across the province, and they have been a real driving force behind the serious illness conversation training for various disciplines across the province. So they've been very supportive and accepting of our work and key partners. So that is what we had to say this morning, and like I said, our hope, bringing it back to the beginning, is that we have been able to provide some guidance, some assistance, at least make you aware of the resources and tools now available that can help you in delivering care as you journey through end of life with your patients. So thank you very much. I'll open it up for any questions now. Should I start with the other sites? Sorry, Mahmood? Yeah. Mahmood? Any comments?
Can you hear me?
Yes.
Well, I'm amazed to see how much work has been done in the last few years and how it's all come together. And having the patient voice at the center of developing this is wonderful. So just keep up the good work. It's excellent to see where we're at.
Thank you so much. For those of you who may not know, Mahmood pioneered this work, Dr. Karim, so we owe you a debt of gratitude. Thank you.
Hi, Gaylene. It's Sunit. I don't think you can see me on Diamond. Oh, there it is. Oh. Just a question, when you and Sarah and your team were engaging with patients, I wonder whether or not a lot of patients or any sort of said that they feel like they get a lot of education, but they're often looking back towards us to ask what we would do, or what we would do for our parent or our brother or sister, etc., and whether or not they think that's of value. Because sometimes I feel like we give a lot of education, but a lot of times people just actually want not another statistic or a piece of information, but some idea on what we think would be best for them, and whether that came up in patient conversations.
Thanks so much, Sunit. It does come up, and I think that's a testament to how close a relationship we develop with our patients. They wouldn't ask just anyone that question. You know, that's experiential, and what I've found is my response to that has actually changed over the years as I've gained more clinical and personal experience. I mean, if we self-reflect, and as we get older, I'm of a certain age now, so you perhaps have experienced loss of a loved one in your own life. And that, we have to be honest with ourselves, that influences how we guide and advise our patients. So I don't dismiss that question ever. I don't defer it. I do take it head on, and I'll be honest with them. But I find that it's difficult to answer that if you don't know your patient really well. So it comes out of relationship. If you know your patient well and what matters most to him or her, you'll be able to answer it very effectively, and they'll be very grateful for your personal opinion.
Gaylene. Hi, Gaylene.
Hi. Is that Renee?
Yes, your presentations were wonderful. I guess I have two comments. One is the caregiver, personal spouse, and a personal perspective. So very important when you're having these meetings with family, make sure the players that are going to be helpful to the patient are in the room. It can't occur through a telephone call. It can't occur through long distance discussion. And you need to have nuances, facial expressions. When you're meeting with the patient's family, they're key players as things get closer to the final decision process. And I know you brought that forward, but I'm just underlining that again as being very, very important. The second part is a comment about where nephrology is receiving patients from other groups and specialties. We are receiving cardiorenal patients. The patients are diaries to the nth degree. They end up on dialysis with blood pressures of 60 systolic. I'm not kidding, you know. We have oncology, genitourinary, where the patients are getting chemotherapy, their kidneys go down the hill, there's nothing further, but they are passed over to nephrology to carry on while things might or might not improve. And unfortunately, there seems to be a dilemma that the primary group that carries on is the team called nephrology. I don't mean to put down these other specialties, but they sort of pass the buck repeatedly, and we go with it. That's the way life is, and that's what will keep on increasing in numbers in the future. And I thank you again for what you've done.
Thank you from the bottom of my heart, Renee. I really appreciate you highlighting the point of interest and our focus on the patient being part of a group of people. I always want to speak with the patient and, as I call it, his or her inner circle. That may be family, close friends. You're absolutely right. It needs to happen in person. I'm very old school that way. I mean, sometimes with technology one can arrange a video conference, but there's nothing better than an in-person meeting where you can have a better idea through body language and facial expressions, etc. And then to address your second comment, which is becoming increasingly common, and in fact, reflecting myself on the death of a patient I was involved with that happened, you know, just 2 days ago. She became mine, but really was a cardiac patient, and she had a very tumultuous course at the end of her life, despite a long illness journey. And I'll share this, and again, I don't mean to offend my colleagues in other disciplines, but I find it interesting that the serious illness conversation often falls to us, that it has never been initiated earlier on in the trajectory of a life-limiting illness, whether it be cardiology, oncology, gastroenterology for patients with end-stage liver disease. You know, I see some nodding heads. I think we all know what this means, and you're right. We end up being the final destination as the service that provides their end-of-life care. And our hope is that not only will we continue to provide excellent care for such patients at end of life, but that we will engage our other disciplinary colleagues to get on board with earlier, better conversations. And we are starting to see that in our cardiology group in Victoria, thankfully.
Hello? Hello?
Hello? Yes? Yes?
Oh, hey, Gil Kimmel from Palliative Care at St. Paul's. Thanks for the presentation, and thanks also to Adira for telling me about this. This is great. My only comment would be that, you know, the Palliative Care team at PHC, we're very happy to work with you guys and to help in these conversations. I will say that I think, you know, the latest literature really identifies that the nephrology team sometimes is the best to have the conversation just because you guys know the patient the best, and we're there to support and fill in and reinforce the message. But I'm not sure that sometimes the allied healthcare providers know the patients as well as the nephrology team, because I think that's very unique to the nephrology practice in general. But that's just what I've observed. But anyway, we're happy to work with you guys. We have our outpatient clinic also for patients that are ambulatory that want to focus more on pain management and also end-of-life care goals.
Yes, Adira has a question which I'll repeat.
I think that there's an interesting tension in the emergency room when I watch general medical residents and people who've never seen the patient revisit the notion of do you want to be resuscitated when the discussion has been had with the team that knows them very well. And I know it's the rule to always react. I wonder if there's some way we can influence the asking by people who are strangers in 2 o'clock in the morning as if it's some kind of an emergency. And I find that quite sad to listen to, because I've had patients say, did I give the wrong answer last time? Why did they ask me again? And I think we have a little bit of work to do, and I think there's residents here, but I just wonder how we can do that best. It's a long question.
Yeah, so what Adira was asking or commenting on was the observed tension when house staff, you know, those in training, or be it a house physician, you know, another discipline that's admitting the patient, is re-asking about end-of-life care goals of care the most. And, you know, it's already been well documented and discussions have been had prior to that with the team that knows them best. And it often leaves patients conflicted. I hope I'm representing that well, Adira. So, and they wonder, you know, if people continue to ask me, am I giving the wrong answer? You know, did my answer differ this time from last time? Because sometimes, and this has been my experience, the patient's been asked in a different way, albeit, and this is by a stranger, right? This clinician doesn't know the patient at all, hasn't established a relationship. And when you get round to coming to see the patient that you know well, you discover the most is now something very different from what was previously documented. And that's alarming. It's alarming to me when I know this patient was a C0 clearly, and now is suddenly a C2, and or vice versa. But you know, I think it's important that we engage our residents, house staff, those who are on the front line, who are admitting the patient at 2 in the morning, that we help them realize that yes, we as the primary nephrologist, it's been pointed out, we're the best at doing this. But really, what makes it best is that we have an established long-term relationship. So get us collaborating with you early on, and not only that, come to us with any kind of educational opportunity you may want. So I was delighted when the house physician group, the hospitalist group at RJH approached me about giving them a lunch and learn session on our documents, what's available around stopping dialysis, And through that presentation, I hope to get some roundtable discussion around these conversations that happen at 2 in the morning. So I was really delighted that they asked me to do this. And it actually, believe it or not, this ask by a hospitalist came about because she was sitting next to me as I was having, sorry Renee, it was over the telephone, my bad, but I was having a conversation around end of life with a patient's wife. She was up in Campbell River. She herself was dying of metastatic ovarian cancer, and her husband was at the Royal Jubilee Hospital in Victoria post-revascularization of his leg, and that had failed and he was about to lose it. And he had expressed a desire to stop dialysis, or he was expressing a desire. And so through that, this hospitalist who was sitting next to me overheard my conversation, and she said, I can't believe how seamless that was. That seemed to go so well. You must know that patient really well. I said, actually, I've known this patient for 5 days, but this is what we do. And she said, I feel like we need to hear more from you about, and then I actually had the stopping dialysis documents in my bag. I pulled them out. She said, can I have them? And I said, yep, I know where to get other copies. So she took them and is going to share with her house physician colleagues. So that's how you get the word out. I just encourage everyone to consider that.
Gaylene, I just wonder if you have any thoughts of what is going to happen with MAID and whether or not it will evolve to the point where people can have plans established and cross the boundary where they're considered no longer competent, and that plan can still be carried forth.
So what Gary was asking about was around MAID and how things might evolve, because our government is being pushed to modify the legislation because of the Quebec ruling, and whether patients may still be able to have it provided even if they become no longer competent. Is that reflecting the question? So I do believe things are going to evolve. I believe our patients, as they become more knowledgeable about MAID, will have an assessment for it to be deemed eligible early on in the trajectory of their illness. More of my patients are doing that. And what they say to me is, I just want to know all my options. I may not follow through with this, but I want to have it available as an option. And for current state, based on present legislation, what I find our MAID providers are very compassionate about is the expedition. So they will expedite. That 10 days is most often not required for our patients. So for instance, in the most recent patient that I was involved with had severe cardiorenal syndrome. Blood pressure was 60. She had decided that she just could not carry on with, and she had just started dialysis 10 days prior. I knew her for 10 days, but yet I felt I knew her wishes very well. And she was assessed, first assessment one day, second assessment next day, MAID provided the following day. So that 10 days became actually 1 day. So that's current state, but will the legislation change such that it can be allowed that patient has it provided no longer being competent? I don't know. I think there is so much controversy still around it and protecting those who are vulnerable, quote unquote. I'm not sure that the legislation will change that much, but thankfully we have compassionate MAID providers who will expedite things. Any other questions? Thanks, everyone.